All right. Hi, I'm a professor at the Joint Medical School, and my research is on the new child health pandemics in the global world: junk food, tooth decay, malnutrition, and obesity. What's happened over the past 30 years? We've had a shift from the traditional diet to the junk food diet. We have our Children's Oral Health and Nutrition Project in all of these countries: El Salvador, Ecuador, Peru, Vietnam, Nepal, and India, and we're finding the same thing: the explosion of junk food consumption that's leading to tooth decay, mouth pain, and malnutrition, and now obesity in children. Some of the research questions that we're studying: the baseline prevalence of early childhood junk food consumption, tooth decay, malnutrition, and obesity in each country, the associations between these factors, the impact of our community-based nutrition and oral health intervention, and the similarities and differences across countries and regions.
My name is Sherry Kais. I'm a clinical faculty member with the Maternal Child Health Program and the principal investigator of the Best Baby Zone Initiative, which is a Kellogg-funded, multi-year, multi-sector project, WK Kellogg Foundation. The focus of our work is to transform communities in order to reduce infant mortality, low birth weight births, and preterm birth. This is our logo, and our tagline is Best Baby Zone, where communities thrive and where babies are healthy. We are a multi-sector approach. We're looking at involving people from the economic, actually I got nervous, from the economic,
So fast.
education, community services, and health sectors to work together with communities to transform those communities. As you all know, where you live affects your health, so we're looking at creating more invested communities and less disinvested communities in order to create environments in which people will thrive.
Jody Halpern. I'm just going to cover two aspects of my work. One is on emotions and health decision and caregiving. Biggest predictor of effectiveness in clinical care is actually empathy as measured. And now I'm collaborating with neuroscientists around the world to find out the determinants of that and improve how we educate clinicians. And my other aspect of my work has to do with public health ethics, social justice. Just did a collaboration with the Federal Reserve. They're getting banks around the world. This came out yesterday. Ethics of pay for success. How to get people around the world who are measuring and monetizing health outcomes to think about social justice. Thanks.
My research focuses on the social and cultural determinants of the health of street children in Kenya and homeless youth in California, as well as other marginalized youth populations. It's well accepted that street children and homeless youth have poor health outcomes due to individual level factors and also due to catastrophic factors at the family level. For the last 15 years, I've been focused on the influence of street level factors, including social networks and street culture, on their health. Our findings are leading me to focus next on modifiable factors at the community level and societal level, including interventions to address stigma. Community leaders in Kenya use different words when describing children who run away from their own communities, using words such as mother, father, and school, versus when describing street children or chakora, using words such as dirty, steal, and sniffing. How does stigma contribute to these young people's poor health? How could addressing stigma increase community reintegration, decrease institutionalized violence, their HIV risk, and improve their health?
Okay.
I'm working on a lot of different things, but I just want to talk about the most fun thing that I'm working on right now, which is a new grant. We're working on the logo. We don't have that yet, but it's called Health and Environmental Research on Makeup of Salinas Adolescents, and that stands for Hermosa, which means beautiful in Spanish, and it reflects our study population, which is Latina teens. All of my work works on endocrine disrupting chemicals. These are chemicals that act like hormones, imitate estrogen, for example, and they're present in a lot of makeup and personal care products, so that's why we're focusing on teenagers, because they may be very highly exposed and they're at a point of reproductive development, so we're concerned. So what this study will do is we're going to enroll 100 teenage girls in Salinas. We're going to determine what personal care products they've been using. We're going to measure these chemicals in their urine. Then we're going to give them low chemical products for a week, bring them back, and see if we can lower their levels of chemicals. And one of the things that's really fun about this is that we're going to be working with teens in the community to do this study. So we have a group of teen health educators we've been working with. They've been helping us design the study this spring. We're going to hire them as research assistants over the summer to do the recruitment and data collection, and then they're going to return the results to the community and do advocacy projects.
Hi, I'm Lori Dorfman. I direct the Berkeley Media Studies Group, which is part of the Public Health Institute, and I'm with CHHD. We study the news media for how they portray different public health issues so that we can equip advocates to do a better job when they're talking to reporters and policymakers to make policy change. We are right now in the middle of a big study with Dick Daynard at Northeastern University studying how personal responsibility arguments have been made in tobacco contexts and in obesity contexts, in litigation, legislation, and news coverage. We've also been studying a lot on digital marketing, junk food marketing, so we can understand how food companies are sending ads directly to kids' cell phones as they approach McDonald's. And you can find all of this in more of our studies, which we do a lot of self-publishing, so we get it right into the hands of advocates, but also in the academic literature a little bit, and you can find it all on bmsg.org.
Yeah. So I'm Julie Deerdorf, and I'm in the maternal and child health program in CHHD. One area of study right now that I'm focusing on is early exposure to adverse circumstances early in life, both in utero and in childhood, and the emergence of sexual risk-taking among youth, among adolescents, both boys and girls, and how substance use contributes to that. So right now, I'm working through a Hellman grant with Brenda Eskenazi on the study that Kim was mentioning, part of it, which is chamacos. And we also have an R1 submitted. We're going to find out in June how it did. And we want to look at these processes, but also look at the biological mechanisms that might underlie some of them, including pubertal timing, hormones, maturation, and stress responsivity. So we're going to be looking at cortisol and also ANS function.
Hi, so I'm Emily Ozer from CHHD, and I just wanted to share some of the research questions that have motivated my work and in the past and moving forward. So one big question for me has been how participatory research processes things enhance youth development and interventions, and I've just mentioned some of my collaborators in this project. Another big question for me has been looking at economic empowerment and conditional cash transfer programs and really trying to understand what are the social psychological conditions that enhance the effects of these economic interventions and what are some of the psychological impacts. And you can see some of my collaborators in the school and beyond. And I just put in a proposal in December for a culture and health interdisciplinary network to really understand and measure better how culture and health relate to each other. And you can see some of my colleagues at the table and throughout Berkeley. And then I'm waiting to hear on a proposal that's a collaboration with a faculty member in the psych department who's a sleep researcher. And we're developing an intervention to promote sleep among teens and to look at how that affects mental health and substance use. Thank you.
I'm Seth Holmes. I'm a second-year faculty member here in Health and Social Behavior and the division. I'm trained as a medical anthropologist and also a public health physician, and I go like this. I have two primary research questions that run throughout all my projects. One is what mechanisms run from social hierarchies to health disparities, and the second is how do social hierarchies and health disparities come to be understood as normal and natural so we don't notice them anymore. I do qualitative research, mostly ethnography, participant observation, but modified with other methods. I have a project that's finishing now where I migrated from the US to Mexico and back with a group of undocumented indigenous Mexicans, and a book called Fresh Fruit, Broken Bodies, Migrant Farm Workers in the US is coming out May 20th, and it already has great advanced reviews from Paul Farmer and Sir Michael Marmot, which I'm very excited about.
Hi, I'm Sylvia Gendelman, chair of the MCH program, and quickly, I'm currently doing work in 3 areas. One is on maternity leave, the health benefits of maternity leave and how to improve uptake of maternity leave among working women. And then I've got 2 studies that have been the continuation of long-term work in the area of Mexican immigrants in this country, but looking at birth outcomes and now overweight and obesity in immigrants from a binational perspective. So why maternity leave? It's really important because we live in a country that is very ungenerous when it comes to benefits for maternity leave. Of the 19 industrialized countries, the US is the only one that doesn't pay for leave and gives us only 3 months or 12 weeks of leave, which is job protected but unpaid. And this is unfortunate because 50% of the workforce these days is female. And the point is that business is beginning to acknowledge that, but we still, when it comes to social legislation, think of it as a male-dominated workforce.
Hi, I'm Bill Saturiano from Health and Social Behavior. Let's see if I had the right. Okay. And my areas of interest include studies of health and well-being in older populations, place in health, cancer disparities, and most recently, and what I'll focus on in the remaining time, is some work that we're collaborating on with colleagues at the Social Apps Lab at Citrus, and that is the development and evaluation of mobile interactive devices that promote health, and particularly physical activity, and it's Bingo Walk. And this is just one display from the game, the interactive game, and as you can see, as the name implies, we're proposing an active form of bingo. On the left, you see the bingo card. On the right, a map. This is played on an iPad in three-person teams. And once you identify a route, icons appear. As the teams reach those icons, the bingo letter numbers appear. It's the way you play bingo. And we're trying to develop, again, the most effective games, but also to ensure adequate access.
Hi, my name is Ndola Prata, and what I'm going to be talking about is a project that is part of implementation research that I lead at the Bixby Center. So in this project, what we're trying to do in order to increase access to contraceptives to rural women in Ethiopia is to combine social marketing and community-based distribution strategies to address the distribution and financing challenges that the country has to increase access to contraceptives. So what the project entails, and we are already at 18 months in the project, is that we train the community health workers to provide injectable contraceptives. These community health workers, they act as social marketers, so they sell the contraceptives to women for 5 births the local currency. The women pay, they keep 2 births with them and pay back 3 births to a drug revolving fund that then is able to provide free services for the 25 to 30% of women that cannot pay. Thank you.
Okay, I'm Denise Hurt. I'm in health and social behavior, and I'm interested in the relationship between culture and health disparities in many different forms. And I have three things that I'm working on right now. And one is there's the picture, which is worth 1,000 words. Just in terms of, I'm interested in the influences of economic and industry factors on popular culture. Popular culture is really important for youth behavior, influencing all kinds of things. I'm looking at alcohol, drugs, violence, and sexuality, and how it's portrayed in this media and its impact on youth. The other thing I'm interested in, or another area, is how communities construct health and social problems. Their constructions often don't relate to medicalized versions of issues, but they're more interested in things like public safety, community, and economic development. And I think these are, very important to understand, just in terms of how do we frame interventions that really resonate with communities. Thank you.
Hi, I'm Amani Narujita, a faculty member in CHHD in epidemiology. I do work in social epidemiology on racial disparities in health. I just completed data collection on the African American Women's Heart and Health Study, a pilot project designed to examine the association between chronic stress and both subclinical cardiovascular risk and physiologic aging among African American women. Preliminary analyses show that the combination of chronic experiences with racial discrimination, along with anticipatory racism threat, a form of stress appraisal, and superwoman schema, a culture-specific coping style characterized by this global notion of strength, is associated with a heightened subclinical pro-inflammatory state, which is an indicator of both physiologic aging and cardiovascular disease. The results are being used to support an R01 project, which is a collaboration with Jeffrey Ogan, the chief of cardiology at UCSF, and more importantly, the husband of Chris Mattson. Thanks. Dr. Ogan runs the Healthy Heart Study, which is a technology-based project examining the predictors of cardiovascular disease in a national cohort of adults My project will use the technological infrastructure of the Healthy Heart Study, employing survey tools, biosensors, and mobile apps for real-time collection of health information. Thank you.
I'm Julia Walsh. I'm a professor in maternal and child health. I'm going to talk about one of the aspects of my work, but all of my work, I would say, centers around the analysis of costs of interventions and healthcare systems and insurance impact and benefits. Right now, I'm involved in the cost analysis and the impact and benefit analysis with a variety of students and other faculty of 4 different e-health interventions. My work has primarily been in developing countries, but several of these are also for the domestic work. Immunify is a tracking system to improve immunization coverage rates. It's going to be have a usability testing in Uttar Pradesh this summer, where fully immunized children are only 40%. IDOC 24 is used here for domestically, and it is for improving and making more rapid melanoma.
Hi, my name is Rachel Moreno-Frosch, and I'm in the School of Public Health and in the Department of Environmental Science, Policy, and Management. I'm an environmental scientist by training, and my research looks at environmental justice questions in terms of racial and socioeconomic inequality drivers of environmental health disparities. I look at this in the context of air pollution effects on birth outcomes and also environmental chemicals. I'm interested in the interactions between psychosocial stress and environmental stressors. I'm also interested in extending the relevance and reach of my research. I do community-based participatory research methods in terms of my data collection efforts with many groups. I also am very interested in the role of environmental or health social movements in influencing scientific thinking about environmental health problems, which is sort of my social science side. And I'm also interested in ethical questions related to biomonitoring of marginalized communities for environmental chemicals and questions of stigma and stressors associated with that. And finally, I'm interested in translating the results of my risk assessment and epidemiology for tools for decision making.
I'm Chris Madsen. I'm a pediatrician in the Joint Medical Program and Public Health Nutrition, and we look at youth's environments, where they spend their time, to try and figure out how we can improve the physical activity and nutrition opportunities that kids have throughout their day. We work with local health departments, schools, and community-based organizations doing research to try and affect policy to influence change in youth environments. And just a quick snapshot of some of our studies. In the neighborhood, we've done a randomized controlled trial of a national after-school program that just came out in JAMA Pediatrics last month. And we're doing a longitudinal study of thousands of youth in San Francisco looking at how they get to and from school. In the school setting, we're just finishing up a randomized controlled trial of Playworks, a national organization that works to structure recess for kids. And we're looking at San Francisco's physical education to see if we can improve the quality and quantity that kids get. And finally, in the home, we look at messaging to parents. We have an RO1 that's going to start in July, and we'll look at how to effectively communicate risk of child health problems to parents and see if we can affect their behaviors in the home. Thank you.
I'm Barbara Laraya, and I'm in Public Health Nutrition. And we launched yesterday the Sustainable Food Systems Institute, and I'm the liaison for School of Public Health to this new institute, so I invite all of you to get to know that. And it's germane to my research because I do research around access to food. So I'm mostly concerned about 2 exposures. One, the built environment and lack of access to fresh, healthy foods, and also household food insecurity, which is increasing in the United States. So those studies are, I have a large RO1 that looks at neighborhood effects on diabetes outcomes with colleagues at Kaiser and UCSF. And I also have another study that's completely a departure, but it's a mindfulness-based stress reduction, healthy eating, and active lifestyle intervention with colleagues at UCSF. And we target low-income, overweight and obese pregnant women, and we're trying to help them gain appropriate weight. And 100% of them are food insecure, so it's really tragic. Thanks.
Good morning. I'm Linda Newhauser. I head the Health Research for Action Center. And my work is centered around taking research findings and translating them to have large-scale impact. One thing I'm doing now is helping the Chinese government address the largest demographic transition in history, the 1 to 200 million rural villagers who are going into the factory zones. And we've heard about the suicides, the increased infectious disease, HIV, and so forth. Chinese government has mostly failed, so they've asked us to come in and use community-based participatory research to engage the workers themselves, the factory owners, health and social service providers, government, etc. We are having a fantastic time. The workers are just incredibly creative, have come up with all these wonderful interventions that appear to be working. If this is successful, we will know that soon. We will hope to extend this, actually the Chinese government will extend this to millions of workers, maybe within the next 2 years.
I'm going to be talking about our research now at the Center for Children's Environmental Health Research. You have probably heard about the CHHD study, which is a longitudinal birth cohort study of an agricultural population in California. We are now doing a similar study in South Africa called the Vembe study. So where are we in South Africa? We're in the province of Limpopo, which is in the northern part of South Africa, where they use DDT and pyrethroids for indoor residual spraying to control for malaria, which is widespread in this particular area. We know that the levels of DDT in the blood of the women in this area are much, much higher than DDT levels were in the United States when it was used up until 1972. We have concerns about the health effects of this level of exposure, and hence we are doing the Vembe study, which stands for the Venda Health Examination of Mothers, Babies, and Their Environment. Which homes are sprayed? We don't know which homes are sprayed, and that's what brought us to developing an app on a cell phone, which we now give to the spray workers, and they record the information on this app on the cell phone, and from that we can get GPS coordinates of where the spray applications have occurred, and that allows us to know which homes are sprayed. And so now we know who's getting exposed and where spraying may be reduced. Thank you.
My name is Malcolm Potts. I'm the professor who wears condom ties. The Sahel is an area of arid land south of the Sahara from the Atlantic to the Red Sea. In 1950, there were 30 million people in this region. Today, there are over 100 million. By 2050, which isn't all that far away, there will be 340 million people in the region. That is also a time when projections from the University of California show the temperature in what's already a hot region will rise 3 to 5 degrees centigrade. This is a mega catastrophe. These people will die, they will be involuntary migration, there'll be more conflict like Darfur. This will be a bigger level of human misery than the AIDS epidemic. It will also generate a lot of terrorism. We're seeing fighting and Al-Qaeda in Mali. Thank you.